So thanks for staying, and I hope you still have energy for this intensive day. So I'm very happy to introduce you to this IBD Symposium, so IBD and endoscopy. And we will touch several relevant aspects of IBD and endoscopy. And we will do this through one live case at endoscopy. So we have the honor to have Professor Bishops to do a Crohn endoscopy. Then we will have two lectures. The first one about endoscopic scoring systems by Professor Ferrante from Leuven. The second one about strictures in Crohn's disease by my colleague, Dr. Heldorf. And then it's my pleasure also to introduce you another colleague from UZ so Dr. Van de Putte, our colorectal surgeon. He will stay with us as moderator here. And then we also have Dr. Bart at the endoscopic room as moderator. Yes. Philip, do you listen to us?
Yes, we do.
Okay. So Philip Bart is a gastroenterologist. He's also focused in IBD. And actually, he's the current president of the Belgian Association of Crohn and Colitis. So for sure, a great panel of experts to discuss these topics. So Professor Bishops, for those who were not yet this morning, apart from being an expert in advanced imaging, he has been very much involved in several clinical trials. In particular, also in one of the first, probably the first trial comparing Chromo versus MBI. So it's really a honor, Raf, to have you again here, and we are looking forward to your feedback. So please.
Thank you, Adriana. We're first going to introduce the case.
Yeah, this case is about a 61-year-old female with a history of ulcerative colitis since 2002. Firstly treated with 5-ASA, and now she's on vedolizumab since 5 years. She also has PSC. She had active inflammation with backwash ileitis in 2015. But the last couple of years, we saw no disease activity on ileocolonoscopy, with the last colonoscopy in 2019, which showed histological remission as well with the use of chromoendoscopy. ESGE recommends the routine use with targeted biopsies of dye-based pancolonic chromoendoscopy or virtual chromoendoscopy for neoplasia, surveillance in patients with long-standing colitis, which brings us to the next question. So please vote. In your practice, when performing dye spray chromoendoscopy, when do you take biopsies?
So while the people take the vote, Philip, it will be interesting to see what they are voting for and to see what the real practice is. So let's talk about surveillance and UC, long-standing UC, and the prerequisite to perform a good surveillance. I think we can see this nicely illustrated here. The first thing is to have a perfect bowel prep. Exactly. And a good bowel prep means like BBPS2 is okay if you can clean anything off. And then no residual inflammation. And here we can accept like small erythema, that is okay. A little bit of edema, that's okay. So it should not be Mayo 0, 0, 0 all over the place. But if you have a lot of ulcerations and it's full of erosions, then it becomes very difficult to distinguish inflammation from neoplasia. So this is the ideal setting. The patient is well sedated. We have a good bowel prep, a perfect bowel prep as a matter of fact. And it's a good indication as well, long-standing UC in combination with PSC. So this is one of the risk factors that qualifies as for yearly surveillance.
If I may interrupt you, if you see a patient with active disease, that means that you will advise to treat the patient until the mucosa is healed, ideally, and then have a second look later on.
Yeah. So it depends a little bit on the situation. It's a very good question, actually, because we are still faced with the patient as such, right, that comes for surveillance. And obviously, it's not like I will pull out my scope and don't look, right? So that's the first thing. So you can still look for things that look dodgy, but anything you biopsy that looks a little bit elevated and comes back as low-grade dysplasia, like with the artificial intelligence, you need to also interpret the histology and say, well, maybe this is not the case, there was inflammation still there. Yeah. But in fact, yeah, if it's like Mayo 3 all over the place or very severe, then I just don't do the surveillance as such. But if somebody comes back after step-up therapy and there is still inflammation, then I would try to do it. Sometimes in that case, I still take the 4-quadrant random biopsies every 10 centimeters.
Okay.
Okay, so let's discuss what we could do. So Triana, you already alluded to the virtual chromatoscopy versus classical chromatoscopy. So because the classical interferes with what we do and with the virtual, then we're going to show this first. And what we showed in the trial is that actually this is a very nice way to proceed because it can highlight the lesions and it detects just as much lesions as it does with chromatoscopy. And just to show you how we work and what should draw your attention, I hope you can appreciate here, which is now at the 12 o'clock position, something that's a little bit whitish from the distance. And these are the kind of lesions that we look for, right? And if you see something like that, then you would try to go closer. You see it's a little bit nodular, so it's like a slight type 2A lesion. But then you come closer. You can find a lot of these lesions in patients with long-standing colitis, and you can see actually that the pit pattern is mostly the same as the surrounding. So most of the time this is then non-neoplastic, but if you look in the center, there's a little bit change in the pit pattern here, right? So this may be something, it's a type 3, and if you look at the top, it's a type 1. So the round pits you can see at the top at 12 o'clock is a clear normal pit pattern, and if we move down, you can see change here, the so-called demarcation line we were talking about. And then we see what's coming up here, which looks a little bit like more type 2 and sometimes type 3. I would warn against just starting to get your snare out in the case of previous UC, although it looks very tempting, and we can show the demarcation line again that David was talking about. And this may very well be an adenoma or at first sight, but very often we find these spots quite numerously in case of quiescent colitis or absence of colitis. So I would always biopsy a larger lesion like this first before engaging into an EMR. We know where it is, so again, the photo documentation is crucial, right? Oh, sorry, so it's probably this. So we take a picture and we describe where it is. It's right at the cecum, so sometimes you can take pictures in referral, and that's one of the advantages of using then also the virtual chromatoscopy, that you can actually just take the reference picture in white light so people know, okay, you can see the cecum there, you know where the lesion is, right? And we definitely need to biopsy that. So although we try to avoid to take too many biopsies, we want to take targeted biopsies, and these are the areas we would like to target.
Raf, can I interrupt you?
Yeah?
So as you were saying, in these IBD patients, you have sometimes these kind of patterns, sometimes related to the chronic disease, so you wouldn't act like in a non-IBD, doing a resection directly. Which kind of path do you see this often? Like, is this a problem, a limitation, the chronic changes in the mucosa? Is this a limitation, you think, for chromo, virtual or standard?
No, it's definitely not a limitation. It's just that you at least focus your biopsies on what might be interesting, right? So if you look throughout the studies that do targeted biopsies, about 1 out of 4 biopsies turn out to be neoplastic. So that means you can find a lot of regenerative changes in the case of UC, which are not relevant to take out. And it's just something we need to accept. On the other hand, we know that if we do these techniques, in about 1 out of 5, 1 out of 4 patients, you don't need to take any biopsy at all, unless you want to assess maybe residual histological inflammation in the rectum, right? But at least we need to focus our biopsies on what might be interesting, and realizing that in many cases, this may be nothing, and then we don't need to act upon it. So that's why, in contrast to normal colonoscopic screening, we just don't take anything out unless it looks, I mean, if you would find here a small adenoma, which is typical adenoma, then you can snare it out. But for the bigger lesions, you might end up resecting a lot, which is not relevant. And we can see that this used to be pancolitis because you can nicely see the scarring here in the middle of the screen, right?
Mm-hmm. And yeah, talking about scars and resection, I guess this is another problem, right? So resecting, if you would decide to resect, it's something that you need to take into account?
Yes, and the reason the more to make sure that you're going to resect the lesion that needs resection, right? I mean, if you're just going to resect every regenerative change in a previous colitic colon, then, well, you're going to do more harm than benefit to the patient.
Yeah.
But at least it's always the same. I just show you the retraction technique, so you really need to search the folds, and actually the cap in this case forces you to go very close and to inspect in detail the entire mucosa. I'm just going to go now back to that lesion, Triana, to show you again the pit patterns and to show you the classical chromendoscopy, right? So we move back to the white light. And in case like this, it's very easy to do the classical chromendoscopy. I think the advantage of the virtual chromendoscopy is that if you have some stool remnants or a lot of mucus, you can still do it and clean while you're at it. I don't know about you, Philip. But if you do classical chromendoscopy and there's a lot of mucus, actually it doesn't work very well. So,
exactly. So we're using a spray catheter here, Raf?
Yes. I still like the spray catheter a lot. I know that the techniques have been adapted, especially, yeah, you can go ahead. So we're just going to show it first. So you put it in the center and then you make rotational movements, right, like this.
So how much of the surface are you trying to focus to reach for here?
Well, we want to stain everything, but the advantage of using methylene blue that we're using in this case is while you are pulling back, and we will be rinsing it off later on, and that will actually already stain the distal part of the colon as well. And because it gets absorbed, it's actually quite easy to stain the entire colon with 100 cc. Okay, we're going to hold it there.
So
okay,
you go up to the hepatic flexure, and then you go back?
Yeah, usually I do around 20-30 centimeters, and then I go back. What also helps to get a good staining is to have the colon collapse. So usually I try to aspirate as much air as possible so that the color gets really nicely mixed and the entire mucosa gets exposed. And it gets automatically absorbed.
So you use suction also the distributed dye?
Yeah. And then we wait for, let's say, 1 minute. But meanwhile, you can already do the inspection and see how clearly these pits are shown. So we were talking about the Kuda pit pattern just before in the plenary session. You can see nice round pits, number one. And this is without any magnification. So with these high definition endoscopes, you can immediately see that. And as a matter of fact, you can sometimes appreciate in the colitic colons that sometimes the pits are a bit dilated or a little bit more type 2, which is usually regenerative. So now let's try to find that lesion back again. So we knew it was here at 12 o'clock. And there it is again.
Okay, there you go.
There you can see the benefit of classical chromendoscopy. And maybe you appreciate now, Tiana and Philip, that it actually stands out better than it did before. I mean, it's a matter of subjective interpretation, but definitely we can see that there is some kind of difference in pit pattern here and there, right? And therefore, in the ESG training curriculum, we suggested that maybe it's the best way to start with this technique because it really draws your attention to these lesions. Look at how nicely this stands out in the background now, right? So this is what you want to detect, and if you find it, then you take biopsies, you document it, you can nicely appreciate the extent. So this brings us to the other point. Should we biopsy next to something that you can clearly see? In my personal opinion, the answer is no. I don't know what you do, Philip.
No, this is a clearly demarcated lesion. And so, if I understand well, your reasoning is because there is a low suspicion of this being malignant, you suffice with doing a biopsy.
Yes, and you can still do the resection afterwards.
Yeah.
So I think it needs to be resected in the end, if I look at it now, but I've often been wrong by finding these spots and it doesn't show anything in particular.
Raf and Philip, sorry to interrupt you. So you were talking about surrounding biopsies, but actually it's not only for malignancy, right? So it's to exclude concomitant active disease. So what do you think about this? Is because you feel completely comfortable? I mean, it's clear that the patient is in remission, so it's in this case not necessary, or in general not necessary for you?
Well, Rav was saying that another indication on top of detecting dysplasia is, of course, trying to detect whether the patient is in histologic remission. But then, Triana, I think we wouldn't biopsy the lesion, we would biopsy a normal or a Mayo 1 maybe looking area.
So what I was alluding to, Triana, was to find neoplasia next to the lesion as the classical down concept from the past. But I think this case nicely illustrates why that this is really obsolete, because, I mean, you can clearly already do histology here. You can see the normal pit pattern here, and then the pit pattern of the lesion, right? So we know where the lesion stops, so there's no need in taking biopsies next to the lesion to rule out neoplasia that you cannot see. Unless you cannot delineate the area, then you could do that. But then you come to the scenic classification. So this is a clearly demarkable, delineated lesion that you can clearly delineate. So if it comes back as neoplastic, which it very well might be, we can just resect it. So you can also target your biopsy. So we interrogated, there are no suspicious areas, but I think it looks very adenomatous. Now if we look at it, she shows very nicely. So what I would do here, I would not target the center, but at least we can, because there's no, like we discussed before, there's no area where the pit pattern all of a sudden changes. And you don't want to biopsy the center. So if you biopsy, just take the edge to confirm the diagnosis of dysplasia or neoplasia. Open, right, close. And then it doesn't compromise your subsequent resection, right? So I think one biopsy is even enough. You can take another one if you want. But at least now we know we were in the area of interest, and we can resect this lesion later on.
So by taking the biopsies at the periphery, you're less compromising later resection. Is that what you're saying?
I hope, at least. Yeah. But as Triana was saying, very often you already have fibrosis in the previously inflamed colon. So I think the main message here is, unless it really looks like a standard classical adenoma, you can take it out. But for larger lesions like this, at least you need to confirm the neoplastic nature before you engage in numerous resections. Another important issue is, now that we found this, is the question, are we going to resect it at the first spot or not? I wouldn't do that, because you also want to focus on the rest of the colon. So now, after finding this lesion, we need to exclude that there isn't anything else in the colon going on. Open?
Yeah. So I will take one of the questions of the public, Ralph. So, someone asked, could be this serrated adenoma?
It doesn't have the features of an SSA, although they are very often reported to be more prevalent in previous UC. But for me, this has the features as a type 3L pit pattern, as we could clearly see now. So it has the features of an adenoma. There is no cloudy-like surface. The borders are very clear. It's all type 3L pit pattern. There's no type 2 pit pattern. So for me, there's also no dark pits like these widened crypts at the top that you cannot see here like we see in serrated lesions. So from an optical diagnosis point of view, for me, this is adenomatous neoplastic features, most of it.
Okay, and then another two practical questions from the public. So, well, one of them is actually in the guidelines, the concentrations and so I think we could skip this. But you personally, so do you have a preference between methylene blue or indigo?
Yeah, I have a preference for methylene blue, 0.1%. And the reason for this, you can see right now, is that it gets absorbed. So I'm cleaning the redundant amount of blue, and you can still see that the color stays around the crypts. We do have now a negative staining, so the colonocytes have absorbed the methylene blue, and you can see now that the crypts are white, and the colonocytes around it are stained, right? So you have these round white pits with blue borders. So this is the advantage of methylene blue, and you can clean on that and it will stay there, you see? So you have a nice continuous staging. And this already stains downstream.
Okay. And another practical question, how do you time foresee for such an advanced endoscopy?
45 minutes.
Okay, good. So I don't know if you have questions, you're Nordic. In the meanwhile, I would like to ask also, so you know this is a very nice clean colon, but sometimes you have not only feces, but also plenty of pseudopolyps that you almost don't see mucosa anymore. And sometimes it's clear that one of them shows more aberrant mucosa, but sometimes all of them have regular, nice, clean mucosa. So Yeah, in those cases, do you have any criteria to select the most big ones then, to biopsy them, or?
No, what you need to do is you need to try to have a good look as you can to the pit pattern. So, and these pseudopolyps, it's like the blink of the eye. You see the round, normal crypts. These are normal. And what you actually need to do is look in between the pseudopolyps. That is where the neoplasia will be. It's usually flat and has a different pit pattern. So usually I try to ignore them. Obviously, if they are too numerous, it can be that it is impossible to screen the patient, and you need to take everything into account. So every case you have to discuss. Yeah. So just as to finish up, Triana, I'm going to show you here, these are these regenerative changes and inflammatory changes. You see there is an area that doesn't stain that well, and there is some disturbance in the pit pattern. But if you move closer, you can actually see that these pits are quite nice round, and there is actually pits that don't stain. So this is more like a disruptive inflammatory pit pattern where you have loss of crypts. So basically you're doing a little bit of histology here.
Yeah, it's a very nice illustration, because initially the colon looked completely normal, and we've only looked at, I guess, 20 centimeters, and we've seen already lots of changes that were not appearing upon white light endoscopy.
Yeah. So it really works. People just need to start doing it. I don't know if you have the poll there, Triana, how many people answered and what the majority said.
So I'm doing the questions. So I see a new one coming. So another practical question: do you use mucolytic during chromo?
No.
No.
Not doing this one. No.
Okay. Then the one of the section you already answered. So to make it clear, because I see 2 times the same question. So if you already mentioned that, so the biopsis is not compromising the future resection, because you were taking the biopsies in the random, because this was 2 times a question. So this, I guess it's clear now. And I see now the answers for the first question. So in your practice, when performing dye spray, when do you take the biopsies? And now I see, 50%. Oh no, it's changing. Okay. Targeted biopsies only. Most of them targeted biopsies then.
Well, that's a good start. And also take your time. And the quality is everything. And in the beginning, maybe take 60 minutes when you start doing this. And I think the nice way to train is to start using it, maybe have a backup with random biopsies for your first 10, 20 cases to make sure you feel comfortable. Then you get to target lesions, you get feedback from your pathologist. And once you've done 20 to 40 cases like that, I think you should be ready to go to virtual chromoendoscopy.
Okay, great. And while we're finishing up, anything on formal training in chromoendoscopy?
Yeah, so we have just formulated that with ESG. So the goal is to go 1 or 2 weeks to somebody who does this, to see a few cases, to get acquainted with the technique and everything. And then you just have to start, basically. So first do those 10, 20 cases with a backup of the random biopsies. Then do 20 cases and get feedback from the histology. That's really crucial. And then once you know what these lesions look like and you have shown a good adequacy in neoplasia detection rate, then you can move forward with the virtual chromoendoscopy, and that's basically it. Anybody can learn this. You just need to take the time and the effort.
Okay.
Okay, thanks a lot, Raf and Philip. So we will move on to the first lecture, and this will be given by Professor Marc Ferrante. Marc, do you hear us? Hi, hello. Not yet. Okay, so Marc Ferrante is a professor at gastroenterology at the University Hospital in Leuven, and he's focused also in IBD. He's a current member of SciComm at the Belgian Association of Chronic Colitis, also at ECHO, and he has been also very much involved in several clinical trials, including studies of endoscopic scoring systems. It's for sure the right person to give such a talk. So, Marc, I don't know if you hear us now. It's pre-recorded, but I thought he was online. Okay,
good afternoon. My name is Marc Ferrante. I'm a gastroenterologist at the University Hospitals of Leuven, and it's a great pleasure to present you some data on the endoscopic scoring systems for IBD activity. These are my disclosures. So let's start off with the case. This is a patient born in 1951 who first came to my outpatient clinic in May 2020. As you can see, he was known for a long time with ulcerative colitis, for which he mainly had received conventional therapy. But then last March, he developed a flare with some rectal blood loss, which was not responding to beclomethasone dipropionate. And therefore, his gastroenterologist had suggested to start anti-TNF therapy. Of course, I was very happy that the patient brought some recent results, including some endoscopy reports. But let's have a look at these reports. The first report he brought was from March 2019, and the report is reading like this: favorable evolution, but no remission. Treatment optimization is warranted. And that's it, no further details. Luckily, he also had another endoscopy report with him from April 2019, and here the report reads: only some itis around 20 centimeters. For the rest, clearly favorable development of colitis, slightly elevated mucosa, of which biopsies were taken, and there's also a plan. So again, certainly not a very extensive report. So why should we use scoring system? I think there is only one reason, and that is for the patients. Because patients will benefit from standardized reporting. This reporting will facilitate communication between healthcare providers. And it will also facilitate a common treatment goal and approach to reach that goal. And furthermore, I think it will lead to less unnecessary and eventual invasive exams. So the role of endoscopy becomes more and more important. You know that initially we were happy with patients achieving a kind of response, later on steroid-free remission, but nowadays we more and more aim to achieve endoscopic remission. And there are even some data suggesting that achieving histological remission becomes more important. So we have to perform endoscopic evaluations, and we do need good scoring systems throughout these exams. So which activity scores should or could you be using? Well, this is a nice overview, already dated from 2013, but showing that there are several scores available, but the most commonly used scores are the ones underneath, and this is actually also what we use at the University Hospital of Leuven. So for ulcerative colitis, we use the Mayo score, we use the UCIS, and in case of a pouch, we use the PDI. For Crohn's disease, we use a simple endoscopic score for CD, so the SES-CD, as well as the Vittria score. So let's go quickly through all these scores. So the Mayo score, I think, is a score that you all should be familiar with it because it's very simple. So here's the scoring system ranging from 0 to 3. What I mostly tell is if you see frank ulcerations, if you see spontaneous bleeding, then it's 3. If that is absent, but you see erosions and contact bleeding, it's a 2. If that is also absent, but you see some mild friability, some a decrease in the vascular pattern, it will be a 1. And if all that is absent, mucosa is completely normal, or there is some signs of disease inactivity like scarring, then it's a 0. And we most commonly regard 0 and 1 as endoscopic response. This score is very simple, but it also has some disadvantages. For example, it's quite easy to get to a Mayo 3, and it's difficult to define difference in the severity once you have one ulcer or some bleeding. So that's one of the reasons why the UCIS was developed, so the UC endoscopic index of severity. But you can see that we look again into the same variables, vascular pattern, bleeding, and the presence of erosions or ulcers. But now we score for each of these sub-items separately. It's somewhat more complex than the Mayo score, but it's still quite easy to perform in your daily clinical practice. I also mentioned that we use a pouchitis score. There is unfortunately only one score at the moment for pouchitis disease activity, the PDI. It takes into account clinical, endoscopic, as well as histological criteria, but I would like to focus on the endoscopic criteria, which are part of the PDI, and we also evaluate these in Leuven, although I have to mention that the score is not well validated, and it's also not that simple to reflect what is going on in the during the endoscopy. So let's switch gear and go to Crohn's disease. So here I would first like you to draw your attention to the CDIS. It's a score which is still commonly used, but we don't do it in Leuven because we think it's too complex to be used in daily clinical practice, and there are good alternatives. So for Crohn's disease endoscopic activity, it's important that you look into all the different segments throughout during your colonoscopy. So the rectum, the left colon, the transverse colon, the right colon, and the terminal ileum. And you have to look into 4 different characteristics: the depth of ulcerations, the involved surface, and this is based on a visual analog scale, and the ulcerated surface. Then you have to sum up all these. You have to divide it by the number of segments that you were able to explore, and you can add some points for the presence of stenosis, whether it's ulcerated or not. So for example, let's imagine that there is a patient who has an ulcerated ileocecal valve, which you cannot pass. The rest of the colon is normal, so you receive 0 over here. You do receive a score for the deep ulcerations, which you see in the ascending colon, and you also then receive a score for the fact that you cannot pass this ulcerated stenosis. And since you are not able to evaluate the terminal ileum, you cannot score this here. The total CDIS in this situation would be 6.5. So what about a simple endoscopic score for CDs? This is a score we currently are using in Leuven. You again see that we look into the same variables, and we do it again also for all the 5 segments like we did in the CDIS. Now here there are some fixed ranges, for example, for the size of the ulcers, the ulcerated surface, as well as the affected surface. And again, for each of these segments, you have to score this. If we go back to the patient who had an ulcerated stenosis of the ileocecal valve, you can see you end up with the SES-CD score of 8. In the post-operative situation, we commonly use the post-operative endoscopic recurrence score, which was developed by one of my mentors and unfortunately recently lost colleague, Paul Rutgeerts. He never called himself the Rutgeerts score, but you are most likely familiar with the name Rutgeerts score. So as you can see here, it was an important finding since the endoscopic evaluation immediately after, or 6 to 12 months after an ileocolonic resection, can already say what will happen with the patient later on. So indeed, patients who had more severe endoscopic recurrence had a higher risk for clinical relapse during follow-up. So this is the classical Rutgeerts score. During the last years, we discussed whether it's not better to modify the score specifically for the I2 because it was kind of a waste bin. So now we split it up in I2A for lesions confined to the ileocolonic anastomosis and I2B if there are more than 5 aphthous lesions in the neoterminal ileum. Important to know is that from the moment that there is also diffuse ileitis between the erosions, then we start calling it an I3, and if it's if there are large ulcers, we call it an I4. In clinical practice, we will most commonly only start treatments from an I2B or higher. In the other instances, I most commonly just follow up my fecal calprotectin before I decide to start another treatment. So what about the endoscopic activity scoring in my daily clinical practice? And I just want to show you how we work in Leuven at the endoscopy department, and it's with a standard reporting system. So the first thing you have to fill out when you start an endoscopy is what the reason is for the endoscopy. And as you can see, one of the options is Crohn's disease and another option is ulcerative colitis. And when the reason is ulcerative colitis, the next question will be whether the patient has a pouch, yes or no. And depending on what you select here, you will be forced to fill out a scoring system. So this is for ulcerative colitis, where the first question will be what the upper limit of inflammation is, and then you have the options of the Mayo scoring ranging from 0 to 3. Next, you also receive some questions to be able to develop the UCIS, with a question on the vascular pattern, a question on the presence of bleeding, and a question on the presence of erosions or ulcers. This is for a pouchitis where you receive all the 6 criteria included in the endoscopic pouchitis disease activity score. For Crohn's disease, it's quite similar. So you see here again for the SES-CD, the 5 different segments that you have to evaluate. And for each of the different items, so the size of the ulcers, the surface of the ulcer, the surface of involvement, as well as the presence of narrowings, you can choose the score ranging from 0 to 3, and the total score is calculated. Important also to mention, and it's easy for the new fellows, there is also the possibility to ask for more information. So if you're not familiar enough with all the details of the score, you just can click on that and you receive the details about the SES-CD scoring system. So the next question for a patient with Crohn's disease will be, the system will ask you whether an ileocolonic anastomosis was assessed, and if it's the case, you will also have to score the Rutgers score, postoperative endoscopic recurrence score. So I just went through all the scoring systems we are using, but it's important also to mention that these scoring systems do have limitations. And first of all, I think it's important to mention that a picture is worth 1,000 words. If you look at these two images, they are both scored a Mayo 3, although they look completely different. Next, it's also important to know that not all scoring systems have been properly validated. There is some inter and inter-observer variability, which was not picked up when they developed these scores. For example, question to you. Imagine a patient had postoperative endoscopic evaluation, so after ileocolonic anastomosis, and you see 3 large ulcers in the neoterminal ileum, but the mucosa in between is completely normal. How would you score this? I would score this as an I2A, because there are only 2 lesions there with normal mucosa in between. What would you do if there is a stenosis at the ileocolonic anastomosis, which you cannot pass? Stenosis is one of the elements of the I4 score, but since this is limited to the ileocolonic anastomosis, I would go for an I2A. Another question, patient with a severe and extensive colitis with deep ulcerations, receiving treatment, only having proctitis later on with 1 simple superficial ulcer. If you look into the Mayo score, this should be twice Mayo 3. We also have to take into account that what we currently have available as endoscopic activity scoring system may not reflect the whole range or the whole spectrum of what we can see during endoscopy. For example, the UC scoring systems that I mentioned to you only allow you to score the most severely inflamed area. Second, ulcerations which are confined to the ileocecal valve or to the ileocolonic anastomosis are not picked up properly with the SES-CD and the CDS because there is no specific item for the ileocecal valve. Is it part of the ileum? Is it part of the ascending column? Or is it not included at all? We also have to recognize that the surgeries we perform are different nowadays, and you sometimes have this blind limb in case of a side-to-side anastomosis. But this blind limb has not been included in the Rutgers score. And finally, and I think that is quite important, is that there is still some discussion what you have to do with ulcerative colitis patients who have some marked friability without erosions. Is it a Mayo 1, or is it, as requested now by the FDA, a Mayo 2? So for those of you who want to have some more data about these scoring systems, I would like to refer you to this rather old paper already from the European Crohn's and Colitis organizations. But for me, what is most important is that you, together with your colleagues, choose the endoscopic activity scoring systems that you want to use and implement this in your practice. And I think it's also important to have a standardized documentation system, and you can add, I think it's quite important to add images to it. And with this, I would like to thank you all for your attention, and also my team for their support. All the best. Take care.
Okay, so now Mark, now I think it will work. Hi. Not yet. Okay. So, yeah, actually, we have no more time, almost no time for discussion. But I think we could just take one question. Philip, I don't know if you would like to comment in this 2A, because this is a matter of discussion. Many times you also never treat them. Also, not those who sometimes you see this very inflammatory anastomosis. So, not only this open ulcerated anastomosis, but ulcerated and inflamed and sometimes stenosis.
It's a matter of debate, but the current studies do not show an advantage or not a systematic advantage of treating those patients. But I think everything depends on the prior history of the patient. If the patient had numerous resections, if the patient is at risk for surgery in the sense that already lung segments were removed at previous surgery, particularly in medically refractory patients, you do want to at least keep a close eye on the patients. What I sometimes do is I take, when I did an endoscopy, I take a calprotectin at the same instance. So because you don't want to repeat the endoscopy every 3 months, but you then have a reference when you have an endoscopy and a calprotectin level,
agree.
you can put them next to each other, and then you know what that particular calprotectin level means in that particular patient.
Yeah, okay. And Dirk, as a surgeon, yes?
I have a question. Do you have the... Is it clear that the scoring system influences the indication to go for a chromo endoscopy, or is it something different?
No, it actually has, it's completely different. So for the chromo patients should be in remission. So the scoring should be always 0, 0, 0, ideally. So yeah, for us it's different. And I guess, Philip, you would agree, apart from this scoring, and Jeroen also, which is very nice and very nice, the system you have in Leuven, but I still think that it's very important, not only the pictures, a lot of pictures, this was also one of the questions here, but also reporting, because it's the subjective aspect, it's also important, I guess.
Of course, I think Mark very elegantly and practically showed how the scoring systems are working, but on top of the scores that you need to put in your conclusions, you also need a detailed description. And some people don't really understand. They say, for example, Mayo 3 in the rectum and Mayo 2 in the sigmoid. You know, you describe what you see in every segment, and then you conclude.
Exactly.
And then if you're an IBDologist, then you can also give an advice if you know your patient. That was a question I had maybe for Mark, but he's not... we cannot reach him, is that we live in a world where everything gets more and more specialized. We have people who do mainly endoscopy. We have people that do maybe IBD clinics. So I think, what do you think in terms of who should do the endoscopy? Should it be an endoscopist, or should it be somebody who's taking care of the patient clinically?
Well, I think the ideal setting should be someone who is taking care of the patients. But then, so as you said, it's almost impossible to be the best IBDologist and the best endoscopist. You have exceptions, and we have it here, also exceptions. But if it's not the case, then I think you should know your limitations and always have a good endoscopy colleague. So this is the case here, fortunately. And as Raf was saying, for instance, when doing chromo, I think it's a very important diagnostic part. This we can do, and then the resection we can give it to the expert.
Okay,
So,
Mark,
Mark,
could you hear us, Mark?
I received several new links in the last minutes, but I'm able to connect now. So
could you hear us, Mark?
So while I was phoning with the organization, I also followed a bit of discussion.
So,
for
the
sure,
question
I
was
think,
regarding IBDologists doing the endoscopy or endoscopists doing the endoscopy.
Well, of course, it depends on your local situation with how many you are, but I have to admit that I am not always that happy if a colleague performs the endoscopy and I have to take decisions on that. Although now my colleagues know that I would like to see images and I would like to see scores. So especially for multidisciplinary team meeting, it's always nice that you can show also the surgeon the lesions that you think that are important. I think not every gastroenterologist can do it, but they have to fulfill some minimal criteria. That's good scoring, good description of the lesions, and taking images.
So we were discussing this, Mark, and I was saying to Philip, I guess you need indeed to know the patient. I think this is crucial, and to know your limitations. So to have one good endoscopist to go further if you don't feel comfortable to do a big polypectomy during a chromo, for instance. I don't know if you have that a similar situation. Also, if you could comment on this for our trainees.
Sorry, can you shortly repeat, because I don't hear it loudly enough? Can you repeat?
So if we are training our assistants, I think it's very important to insist in the importance of reporting properly. And this is, as you said, this is probably very much linked into the patient. If you know the patient, so if you are connected to the patient, if you know the case, I guess you are more involved to do this.
I think reporting is indeed crucial. The examples I showed you are luckily rare, but they're not appearing anymore. I see it mostly in centers where the gastroenterologist has the endoscopy next to him. So at an outpatient clinic, they just say, come, let's quickly do an endoscopy and look, and then just report itis. That's, of course, not a good idea. I'm not saying that scores will fulfill all the things you need, but if you don't use scores, at least you need to describe properly per segment what you are seeing. And the aspects that you have to mention are those which are included in the scoring systems.
Okay, thanks a lot. So I guess we should move to the second lecture, Mark, but you stay with us. Now you do.
Okay,
thank you. So now we move to the second lecture, and it's about strictures in Crohn's disease patients. And this will be given by my colleague, Dr. Jeroen Heldhoff. Jeroen Heldhoff finished the specialization here in UZ Gent, and then he had the opportunity to have a fellowship at St. Mark's in London. And we are very happy that he's back, also with new knowledge. So please, Jeroen, you can start with your lecture.
Thank you, Triana. So first of all, I would like to mention that this talk will be about the situation where medical treatment is not sufficient anymore, so I'd like to stress that. First of all, I've got nothing to declare, and let's start with just defining the problem. So obviously, when talking about a stricture, you need to be aware of what it is. Montreal classification gives you a clear definition. It's a constant luminal narrowing with pre-sphenotic dilatation and/or obstructive signs in the absence of penetrating disease. And then the constrict group, which is actually the Crohn's disease antifibrotic treatment group, has further given definitions for the endoscopic view and for the cross-sectional imaging. So an endoscopic view of a stricture is actually a situation in which you cannot pass the lumen with a reasonable amount of pressure applied without prior dilatation using an adult scope. And then on cross-sectional imaging, there are three criteria you need to be aware of, and those are, first of all, localized luminal narrowing, then a bowel wall thickening, and a pre-stenotic dilatation of the bowel and as you can see, the criteria, they differ a little bit for a naive stricture and for a stricture on an anastomosis. Okay, obviously pathogenesis, up till present, we don't completely understand it, although we think at the moment that it's mainly a healing tissue remodeling response to chronic inflammation in which mesenchymal cells play a major role. And so the concept or the process of inflammation and fibrosis formation gives us a spectrum of strictures going from a predominant inflamed stricture to a predominant fibrotic stricture, as you can see here. So on the left, we've got a naive stricture in the small bowel with a clearly inflamed aspect with an ulcer on it. And then on the right side, you see the other end of the spectrum, a nice fibrotic stricture, no signs of active inflammation. And then, of course, you've got loads of strictures that are somewhere in between. As you can see in the middle is a nice example. There is some granulation tissue, some signs of inflammation, but not as clearly as the image on the left. What about epidemiology? As we all know, Crohn's disease is the situation we most frequently run into strictures, and even up to 10% of patients, they have a stricture at the moment of diagnosis. The longer the disease exists, the higher the chance of developing strictures, mainly in the small bowel. And over the years, we found some associations for development of strictures, such as with smoking, the presence of predominant small bowel affection of the disease, and also the deeper the inflammation, the higher the chance of developing a stricture. But not only in Crohn's disease this is happening, this is also the case in ulcerative colitis, but then obviously in the colon. It can happen in up to 10% about of all patients. And especially in ulcerative colitis, it is important to remember the malignant potential of these strictures. I will circle back to this later on, but nonetheless, the majority of these strictures are still benign. Good, so how to manage these strictures? Well, the key message is just that this is a multidisciplinary process. And these are the three key players. So you see the radiologist, the surgeon, and then the gastroenterologist, who has access to two possibilities, and that's endoscopy and medication, obviously. First of all, we'll head off with the radiologist, and his role is actually a dual role. Obviously, it's important for making the diagnosis of the stricture, for ruling out any surrounding problems such as penetrating disease, abscesses, and fistulae. And up till now, MRI enterography is the gold standard for diagnosis of small bowel strictures. And as you can see in the right upper image, again, the three criteria must be fulfilled. So that means a luminal narrowing with small bowel thickening and then peristenotic dilatation. And this differs a little bit according to the type of cross-sectional imaging that you're using, and this is nicely shown here in the image. Then the second role, actually, and this is a role that is new, pretty new and ongoing and in development, that is the radiologists can also help us in our decision-making in that way that they can help us differ between an inflamed stricture and a fibrotic stricture. These techniques are new, and I must say that up till now, not a single technique is 100% accurate, so still in development. And some examples are given here. So for instance, in the left upper corner of the screen, you can see an ultrasound image with elastometry. The basic principle is the same as in liver elastometry. So the higher the kilopascals you measure, the higher the level of fibrosis. And then the other two images are images of MRI-based techniques, and those techniques are the most frequently used and the most promising up till now. On the left lower image, you see a magnetization transfer effect image, and you can see, if you look well, it's indicated by the arrow, that the red dot in the terminal ileum has about the same magnetization transfer effect as the iliopsoas muscle, so this means there's clear fibrosis. The image on the right is a really technical technique, is texture analysis. I won't go into depth for that one. Then obviously we've got the gastroenterologist, first of all with the medical treatment. This is a bit beyond the scope of this talk, so I would like to just briefly mention that the cornerstone is still the anti-inflammatory treatment options, and the best evidence we have currently for corticosteroids and anti-TNF-alpha treatment for treating strictures up till now. Currently, there's no antifibrotic medical treatment available in routine and daily practice. But obviously, the reason why we're all here and why we're at the GIEQs Symposium is the endoscopic treatment. And the main message I need to give is that the endoscopic treatment of a stricture is just a way of postponing or delaying or preventing surgery in a short message. Reasons for that might be to prevent development of a short bowel syndrome in the end, or as a bridge to surgery to optimize the patient, first of all nutritionally or his inflammatory status, of course. You see the list of endoscopic options we have here, and I'll just focus mainly on the endoscopic balloon dilatation because this is the technique that up till now we have most evidence for and is most used as well. So just to give you an overview, image A is the stricture, image B, application of the balloon, image C, the immediate result, and image D, the long-term result. I will give you nicer images a couple of slides further where we show a nice video as well. Indications for balloon dilatation, it's actually possible in every segment of the gastrointestinal tract. It needs to be accessible, obviously, with endoscopy. But the segment needs to be straight. There can't be an angle in it, and it can't be a longer stricture than 5 centimeters. Contraindication, penetrating disease, suspected malignancy, of course, then the best treatment option is surgery. Good. What about the outcomes? Well, the data that I show here are the data for Crohn's disease and small bowel strictures, because that's the bulk of evidence we have. It's predominantly limited for Crohn's disease literature. And so you see on the short-term response is pretty good, but even technical success rate is surprisingly higher than the clinical response rate. So that means that you can pass the scope immediately after the procedure. Clinical response is obviously the declination in the symptoms of the patient. But pretty good results initially. And then on the long term, on the other hand, as shown by this nice review recently published, it shows that at about 2 years' time, the rate of recurrence is pretty high. So up to 75% of patients, they do symptomatic recurrence and they need redilatation, and even 40% needs to go over to surgery. So it's a good way to postpone or delay surgery, but often there's recurrence and need for repeated procedures. Complication rate, about 4%. Most frequent complications you see here. And there are some risk factors for these complications, and that is mainly the active inflammation that is still present. So I would just like to highlight some technical and practical aspects of doing a balloon dilatation in Crohn's disease, because there's no clear guideline on that in literature. First of all, the balloon diameter. So obviously the higher or the bigger the balloon you use, the higher the chances of making it traversable, but obviously the higher the chance of complications. And there is an exponential rise in complication risk once you exceed the diameter of 25 millimeters. So what balloon do you actually need to use, or what diameter do you need to use? Well, again, I can only give you some practical tips based on an expert IBD survey and some experience here at our center. And so you can see by Bettenworth and colleagues in 2016, they did a survey amongst IBD experts, and the most frequently used balloon diameter was between 15 and 18 millimeters. Maybe just as a good rule of thumb, I would advise not to go over 20 millimeters in size. Good. Multiple strictures can also be treated endoscopically, but then the best advice is just to do it step by step. Don't do multiple procedures at the same time because of the complication risk, obviously. And then colonic strictures, as already mentioned, there's a clear risk of being malignant, more for ulcerative colitis than for Crohn's disease. And then obviously, if that cannot be excluded, it's important to take biopsies, of course, but if it cannot be excluded, then it's best to consult the surgeon to treat your stricture. And now, I need to go back. Yes.
Is the video?
Okay, so we've got a nice video here of an endoscopic procedure done by David Tate at our department here. It considers a 40-year-old female who had a previous ileocecal resection for Crohn's disease, and now we have a clear view on an anastomotic stricture. It's the same image that I showed earlier on, so it's a mixed fibrotic and inflamed stricture still. And you can see that here the endoscopist is using a pediatric colonoscope with a diameter of about 11 millimeters. He tries to traverse, he inspects obviously the mucosa that is lying behind, and in this case we know that it is possible to not use fluoroscopy. And we can just proceed with using the balloon for dilatation. And as you see the balloon getting inserted here, I must say that tomorrow there's a nice session with Professor Delose, a live case demonstration on balloon dilatation as well. So for further technical details, I would gladly refer to him as well. So good to mention that on the device it says the pressure in the balloon 2 atmospheres equals about 13 millimeters. And so as you will see, the balloon is inflated progressively, step by step. And first in this procedure, the endoscopist went to about 2 atmospheres, which is just below 12 millimeters. And then step by step, he increased the pressure to 3 atmospheres and eventually 4 atmospheres, about 13.5 millimeters in total diameter. And you'll see, so he's mobilizing the balloon just to check whether the position is still right. And then right away he will look through the balloon just to check the position, to check if any complication is happening, and to check if he can proceed with further insufflation of the balloon. The next thing that will happen is the balloon will become deflated again. And obviously then the stricture will be inspected. But this is I think the most important thing to show you. You can clearly see through the balloon to check for complications. Okay. Other endoscopic techniques, as you can see here, there are several, but I must say the main message is that up to now the evidence is too limited and we cannot recommend them at present. I would just like to highlight one technique, and this is the needle knife stricturetomy. It's a more recent technique. We've got a few case series in literature and one case control single center study, and these show promising results. So you can see that the opening that is made while doing the incisions is actually a bit bigger, especially in this one. And so results show that it might have a longer standing effect than the endoscopic balloon dilatation. So we wait for future results on this one, I think. And then the last player in the multidisciplinary approach is obviously the surgeon. And the surgeon, we've got one on our panel, so I won't go too much into depth, so to leave some space for discussion. Mainly, he has access to two techniques, which are the segmental resection, and those are particularly used for complicated strictures and for strictures where there is a suspected malignancy. You can also use them for multiple strictures in one single segment if you're aware that, or if you know that there's adequate bowel length elsewhere, because otherwise, because of the recurrence rate, there's always a risk of going over to short bowel syndrome in the end. And as already mentioned, for suspected malignancy, it's a preferred technique, but also for colonic strictures because of the bowel characteristics. What about the outcomes? Well, the main difference is that the effect is longer standing than the endoscopic balloon dilatation. I would like to highlight the second dot here on the slide. Limited resection is obviously the way to go because of the risk of short bowel in repeated resections. But studies in the 90s always have shown that actually the microscopic active disease at the margins does not influence the recurrence rate. And this is a particularly important message because it helps you limit the resection margin as well. And then the other technique you can use is the strictureplasty. This is a bowel sparing technique. You don't resect anything, you just widen the lumen in a surgical way. And obviously not used for complicated strictures, then the segmental resection is the best option. And as you see here, there are over 15 techniques described in literature. The most frequently used, I will show you here. This is in the right upper part of the image, the Heineken-Mikulicz procedure. Longitudinal incision is made, and then a transverse suture is made. This is used for short strictures up to 10 centimeters. Then on the right lower part of the image, you can see the Finney technique. So again, a longitudinal incision is made, and then basically some sort of a diverticulum is made to widen the stricture again. This is used for strictures between 10 and 20 centimeters. And then we've got the Michaelassi, which is a rather non-conventional technique, but this can be used on longer strictures. And I'm aware of one case done in the St. Mark's Hospital by Mr. Warusov-Atane that went up to 104 centimeters in total length. But this is an exemption, of course. All right, so what about the outcomes? Again, the main difference with the endoscopic treatment is the longer effect, but nonetheless, recurrences are frequent. You can see over 4 years' time, a reoperation rate goes up to about 30%. Complication rates, so the most frequent operative complications are mentioned here. Obviously, small bowel obstruction, bleeding, and septic complications due to leakage can occur, and this is often the case in the longer strictures, I think. So there's one specific item of the strictureplasty I would again like to highlight, and this is the fact that some case series have reported that after a strictureplasty, they see that the remaining active inflammation also seems to settle. And so again, this might be an indication of the fact that the strictureplasty should always be preferred over the resection, the segmental resection, because it might have a dual purpose. It might save your bowel length, and it also might have an anti-inflammatory effect. Okay. And so to conclude, what should you remember from this talk? It is that obviously the treatment of strictures is multidisciplinary. EBD, balloon dilatation, is the way to go endoscopically, but the longer effects of surgery the effective surgery is longer standing than the endoscopic treatment. And considering the GIEQs parameters, I must say that up till now there's insufficient data to support other techniques for endoscopical treatment, but maybe the stricture to me might be promising. And then you can see some practical considerations, but obviously I've mentioned those, and maybe it would be best that we go over to discussion for the remaining time.
Okay, so thanks a lot, Jeroen. So unfortunately, we have only 3 minutes for discussion, but this GIEQs is very intensive. So maybe first, Philip and Mark, as gastroenterologists, how strict you are about the endoscopic dilatation when there's inflammation, because this can be kind of subjective. Do you treat, if you see an inflammatory stenosis, short, do you treat it and then do the dilatation, or how you strict? I know.
So if I can answer, so for me it doesn't matter. There is an inflammatory stricture, yes or no. It's more depending on maybe previous or a transmural imaging that I also would like to see. But if it's most often an anastomosis, whether it's ulcerated or not, that doesn't matter. And also in the published papers, we did not see more complications if the anastomosis or the stenosis was ulcerated.
That's correct. In fact, the risk factors for perforation or complications are long strictures, longer than 4 or 5 centimeters, very narrow diameter, younger patients, and also maybe there's a concern for patients on steroids, but luckily we don't have them so many anymore.
Okay, yes, Dirk.
Does the type of anastomosis play a role in dilation?
You mean like the Kono S type
or if it's side to side or isoperistaltic, that it's easier
we were very happy when our surgeons started to do the so-called isoperistaltic anastomosis, so that we don't have to make that 180 degrees U-turn. That helps for more technical matters, but regarding complications, I don't think that really matters.
Okay.
Yeah, but certainly if you have no surgical report and you have a narrow opening at an anastomotic site, it's very dangerous to go in with a balloon. In the case you showed, we could nicely see through the hole that it was in the direction of the balloon. But if you have an end to side or side to side anastomosis, you may end up having a perforation. And then the other question I had for you, maybe Jeroen, if you don't really see the opening or the lumen behind, would you go for dilatation or carefully, or do you send the patient for imaging before you do the dilation?
Well, it depends on the setting that you have in your hospital as well. I think the way to go is imaging. Fluoroscopy can help during the procedure. You can let your procedure be guided by fluoroscopy if you don't have a clear visualization of the mucosa behind it. But obviously these cases need to be discussed multidisciplinary. I think it's always a balance between the complication risk and the risk of success.
Maybe if you scope a patient for obstructive symptoms, it's better to do an MRI first before you do the endoscopy.
Yeah. Mm-hmm.
Okay.
It's important to be aware of the surrounding tissues, possible complications, presence of associated abscesses and things like that. Yeah.
Yes. Okay. So yes, unfortunately, we don't have questions from the public. We would love to continue discussing, but we don't have the time. So thanks a lot, and we will move on to the next session. Bye.